Hello? Hi,
Hello?
this is Wahida. Hello? This is
Hey,
Wahida.
Wahida,
Who's-
this is Ebony.
Hi, Eb, how you doing?
I'm good.
So,
I don't hear
are you able to
Ebony.
hear the webinar? Are you able to hear the webinar?
No.
Okay, because I think we're just having some technical difficulties. Okay, they can hear us talking, so we need to mute
Can you guys
ourselves.
hear me? Can you guys hear me okay?
I can hear you, Nana.
Yeah. Okay, great. When did I drop off? What was I talking about?
I never even heard the introduction. I just saw the slides start moving.
I never heard you begin either. I had to take it from the top.
Oh my gosh. Okay.
Right.
I will start over then. Oh, okay. Well, I'm glad
right.
you all let me know because I was talking for about 10 minutes. Okay. So let me start over. So first of all, welcome everyone. And we are so glad to have you here with us today. This is Nana Khanna from Positive Women's Network USA. This webinar is basically just a brief 30-minute webinar that is designed to sort of go over the main findings from a research report that was designed by women living with HIV to sort of assess the state of services for women living with HIV and how those are changing in the environment today. And this is a short webinar because we wanted to just have something for you all to refer to as you prepare for your events for March 10th. We know a lot of folks have events even starting tomorrow, as soon as tomorrow for National Women and Girls HIV/AIDS Awareness Day. And we wanted you all to have this information in your hands so that you can start using it in any way that's helpful for you as you're trying to move, your own advocacy projects forward in your local communities. We are going to be doing a much bigger webinar next Thursday, March 10th, where we release the full findings from the webinar. That's a 90-minute webinar. And I think hopefully somebody can paste the link for that in the chat box while we're talking so that folks can register for it. Can you guys hear me okay?
Yes.
Can you guys hear me okay? Okay. All right. Thank you. Let me know if you don't hear me at any point. So today, I'm going to talk a little bit about why we did this project, the context for it. Arnita Rogers, our legal fellow, who's done a lot of work on analyzing the data from the project, is going to talk about what we found, and then we're going to present you with some of the recommendations. And then we'll have a little bit of time for questions, but for kind of detailed questions, we're going to ask you to hold those for next Thursday's webinar where we can get into stuff in way more detail because that is a 90-minute webinar. This is really, meant to be sort of a resource for you so that you have some information as you're planning your activities and going to your events over the next few days, probably talking to media. I know a lot of you are going to have speaking engagements and things like that. We know you all are everywhere. So we wanted you to have this information first before everybody else. And we did release a 2-page executive summary of the report that we're going to paste a link to that in the chat box as well during this webinar. It'll also be in the slides presented today. We encourage you to take a look at that. It was released at AIDS Watch earlier this week. The full report, when it comes out on Thursday, is going to be more like 12 or 13 pages. And we realize that not everyone's going to have time to read that as you're going to your events and everything. So that's why we wanted to just sort of give you a heads up on the main findings today so you can be ready. Okay, there's some background noise. Okay, it went away. Cool. So just a heads up, everybody is muted except presenters right now. If you want to unmute at any point, you can press *6 to unmute your line. We just ask you to make sure that there's not a lot of noise where you are if you do that. And you can also write questions and comments into the chat box. So here's what we're going to talk about today, why we did the project, how we did the project, some key findings, the recommendations, and then we want to hear a little bit about your plans for National Women and Girls HIV/AIDS Awareness Day. And so as you probably know, we know that a lot of you are pretty familiar with PWN, and so you know that women-centered care and making sure that there is high quality, accessible, available, affordable care that works for all women living with HIV of all ages, of all genders, is a priority for us. And so that's a big part of why we did this project. It fits into our, our 6-part policy platform. This is one of our huge priorities and will continue to be. And so what's going on that made this important right now? Well, we have the Affordable Care Act, which was signed into existence by our president, Barack Obama, which has created all these opportunities to really expand access to care for people living with HIV and people with any kind of chronic conditions. It also has expanded access to care for a lot of folks who are low income, and we know that that's a significant part of the HIV community. But we also have some states, some governors that have been resisting expanding Medicaid, and so it's playing out differently in different parts of the country. And this is sort of a factor in thinking about how services for people living with HIV, especially women, are going to look in the future. And then secondly, Ryan White has been up for reauthorization for the last couple of years. The community made a very deliberate decision not to push for reauthorizing Ryan White. So basically not to push for reauthorizing means giving it to Congress to basically make changes to update the legislation and pass it again. Well, we know that this Congress is pretty terrible on a lot of issues for people living with HIV and for women. And so we made a very deliberate decision over the last couple of years not to push this Congress to reauthorize Ryan White, to just ask them to keep funding Ryan White as it exists right now, because we don't want to give them any room to cut programs right now while we're still figuring out how Affordable Care Act implementation is working, how Ryan White can sort of wrap most effectively around the Affordable Care Act and Medicaid expansion, what services need to look like in this new context. And also, frankly, I think a lot of us are hoping for a more friendly Congress next time around. And so there's a lot of work to do, obviously, in this election cycle for that. But Ryan White is going to be up for reauthorization sometime within the next couple of years. And we believe that it's important that women with HIV are helping to shape and frame the conversation about what the future of Ryan White looks like. We also know that women with HIV are living longer. And, thank goodness we're aging with HIV, which brings a whole set of blessings and a whole set of challenges, right, including comorbidities, being diagnosed with a lot of other things that we're dealing with in addition to HIV, lifetime history of trauma, that just sort of grows, over the years too. There's also a trend in the external environment towards medicalizing HIV. And we see some of this play out in the Ryan White program in like the 75-25 split that requires, funding 75% of services in Part A, B, C as core medical services, and only 25% as supportive services, the ones that help people stay in care. So there's been sort of an increased trend towards this, and I'm sure, a lot of folks have heard about treatment as prevention and lots of, kind of new focus on just being very, very focused on viral suppression, the care continuum, and things like that. And we know that there's a lot of need for other kinds of services besides medical care. So we want to make sure we keep our eye on that. And then finally, the president's budget this last month, for the third time in a row, proposed getting rid of Ryan White Part D. And so we've been able to successfully push back on that for the last 2 years. We think we'll be able to do it hopefully again this year. But the bottom line is, Ryan White Part D services might get reconstructed at some point. They might look different at some point. Part D may not exist in the future as we currently know it. And so how do we want to set ourselves up for making sure that those type of services are not only still available in the future, but are actually available to more women and more people who need them? So that's basically the context. And so how do we do this? We recruited a bunch of women living with HIV to be community-based participatory researchers. And what's important about community-based participatory research is that it involves community at every step of the process along the way. And so the community being studied or researched is actually designing the whole process and the whole question. So we were basically a big team of women with HIV from all around the country, and we recruited, oh, I dropped again. You guys can't hear me?
I can hear you, Nana. I'm not sure.
Okay, thank you. So we recruited 14 women living with HIV, a couple of which you'll get to hear from if you join next Thursday's webinar, about what that was like to be part of this process. And they developed the questions, designed a survey, recruited participants. And so we ended up basically developing an online survey, and we did it through SurveyMonkey. I think we have Jay on the phone with us today. Jay is actually one of our community-based researchers, and can, probably add in on about this on the chat box as well. But so we designed an online survey. It was distributed through SurveyMonkey, and the researchers, the community-based researchers, not only designed all these questions, they also went out and recruited women to respond to the survey. And so we ended up having 180 respondents. The geographic regions that were covered are listed here on the slide. I won't go over them in detail because we'll talk a little bit more about that next Thursday. So we ended up having about 180 respondents to the survey. And so this is all survey data that you're going to be hearing. We recruited women with HIV who were already basically in care. So they were recruited from community-based organizations. They were recruited from AIDS service organizations, sometimes from clinics, support groups, and sometimes personal networks. And so one of the things that's important to know is they were basically telling us all about themselves. We weren't looking at their medical records or anything to sort of cross-check. So, so all of their data is what we call self-report. So if, for example, if they told us that their T-cell count was, 300, we didn't cross-check that with a medical record. We didn't have any kind of authorization to do that. We took them at their word. And so, sometimes that data is completely accurate. Sometimes it might be a little bit off. We don't really know, but just so folks know, that's what we're looking at here. So I'm going to go ahead and turn it over to Arnita, who's going to tell us about who responded and some of the findings.
Okay, great. Thank you, Nana. Thanks for that intro and thanks for the context. So as Nana was saying, we received, or the researchers were able to collect information from over 180 women that responded to the survey. And so this is just this slide just shows a breakdown of some of the demographics of the respondents to the survey. And so we have age. We had about just over 40% were of reproductive age, which is considered 44 and under, and then about 60% of the respondents were 45 and above. And so we made that distinction because some of the types of care, some of the types of services, especially around sexual and reproductive health care, there might be differentiation between women that were below or under of reproductive age and above reproductive age. So when we talk about that data next week on the webinar, you'll see those distinctions made. We also collected racial demographics of the women that were reporting, and we wanted that data also to reflect the data of the national epidemic. So you see that 67% of the respondents were Black, 16% were white, and 9% Latino. We also had respondents that reported as other or mixed race, but those were not the higher categories counted here. So we just have those three categories here. Probably most significantly, what we found was that overwhelmingly our respondents were very low income or low income. So almost 90% were living below 138% of the federal poverty line. So, and we also use 138% of the federal poverty line because with the Affordable Care Act and the Medicaid expansion, that is the threshold for new eligibility for the states that authorize expansion in those states. And just to give you an idea about what the federal poverty line is in numbers, that is around the federal poverty line for an individual is just under $12,000 of gross income a year, and for a family of three, that would be around $20,000 a year. So you're seeing that our respondents were very low income. We also saw that most women that responded to the survey relied on some form of housing subsidy to maintain housing. So we know that that can also be unstable at times, and that could be either through HOPWA or either some local subsidy that they were receiving, but knowing that their income made them reliant on housing subsidies. Additionally, we saw that regardless of reproductive age, that most women had family responsibilities. They were caregivers and caretakers, maybe for their own children or other family members. But we saw that the respondents had a high number of dependents who were also dependent on this very limited income that they reported. So those resources were often stretched, and also knowing that they were juggling those responsibilities in managing their care. Additionally, most respondents reported receiving health care through some form of public program, either through Medicaid or Ryan White or Medicare or a combination of those. So those are just some of the income and housing instability and family responsibilities. Those are some of the main barriers that the respondents were reporting. However, despite those significant barriers and economic insecurity and maybe being unstably housed, we found that most of our respondents were engaged in care and committed to their health care and committed to supporting their families. So almost all of them said that they had seen a medical provider within the past year, or HIV medical provider in the past year. So this is also, Nana mentioned earlier, that we recruited our participants from entry into the healthcare system, so they were more likely to be in care than a general population of women living with HIV in the country. Additionally, 86% said that they were taking medication daily, and there was a much higher percent, 78.6%, reported being virally suppressed. And so, we know that that is much higher than the numbers reflected in the general population, as only about a third of women living with HIV are actually having achieved viral suppression. Additionally, the data showed us that respondents were dealing with multiple conditions in addition to managing their HIV and HIV-related healthcare symptoms. They were experiencing comorbidities and co-occurring conditions as a result. So 30% of the respondents had diagnosis for hypertension, 21.6% for Hep C, and 17.2% for diabetes. So the overall survey, we treated it as a needs assessment, but looked at trying to gauge barriers to care in different ways by asking different forms of questions. So overwhelmingly, one of the major barriers that the respondents reported was transportation. And we'll see this over and over. So 50% of the respondents who said that they had missed a medical appointment in the past year cited a lack of transportation as the reason. Additionally, transportation was one of the main reasons for missing, not being able to fill a prescription for HIV medications. About 24% cited that as a reason for not being able to fill HIV medication prescription. And as I mentioned before, financial insecurity was a major barrier for women remaining in care. 15% of the respondents who said they had missed filling a prescription also said that a higher copay cost was the reason that they faced that barrier. And also relating back to the slide I just mentioned about managing multiple responsibilities and caring and being caretakers, 50% of the participants who said they needed child care services on site at either their HIV medical provider or a social service provider said they were not able to get it. And this was across age. So we know that, as I was just saying, that women, regardless of reproductive age, may be caring for other members of their family, and this was a huge barrier. Nearly half of those people said that they were not able to get those services. Right. So when our data that we collected around access to sexual and reproductive health care demonstrated what we know is still very pervasive stigma and sexual negativity or sex negativity in regards to provider communication around sexual and reproductive health care for women living with HIV. So the data revealed that just only about 40% of women of reproductive age, 44 and under, had been asked in the past year if they wanted to get pregnant. Similarly, only about 40% of women of reproductive age had asked even if they needed birth control. And then we were seeing disparities as well between women below and at reproductive or above and at reproductive age about accessing care, accessing sexual and reproductive health care, like obtaining a pap smear in the past 3 years. So we saw that 82.9% of women of reproductive age had been able to have a pap smear in the past 3 years, but a lower amount, 74.5% of women over reproductive age, were not able to have a pap smear in the past 3 years. So we know that sexual and reproductive health care is lifelong, and so we want to make sure that when our recommendations, we recommend that they are able to receive that care as they age, as women living with HIV continue to age. Okay, and then so 38.1% of participants said that they had not been told that being virally suppressed would reduce their risk of transmission. So this is huge, and this is, we looked at this number despite reproductive age, and it confirms that women living with HIV are sexually active and should have this information, this very important information. Okay. Mental health services was also an area that we collected a lot of information around, and that we did see women were reporting great barriers, they were experiencing disparities in their mental health, but also reported receiving or reported wanting to obtain mental health services in a variety of ways. So the data revealed that 17% of our respondents had experienced or had post-traumatic stress disorder, and an alarming rate had been diagnosed with depression, nearly 65%. So that is a very high number. Additionally, so with all of those women experiencing these forms of mental health disparities, nearly 2/3 of them said that they would like to see someone, either for counseling or therapy. Additionally, of those women that reported, nearly 2/3 of those respondents of those that reported said 41% said that they would that they were unable to access therapy because of some form of a barrier, either due to cost, either to lack of their insurance or provider coverage, or a lack of available services or wait lists for services in their area. Additionally, there was a high interest in support groups. So 87% of the respondents reported having an interest in attending an HIV support group, but nearly a fifth of them were unable to access one in their area because of some barrier that was reported. All right. So, in a quick summary, just of that snapshot of the data, where our respondents showed, as a snapshot of the population, that women living with HIV are severely low income and have significant family responsibilities in the context of being severely low income. Those women are also living with other health challenges. They're not only just managing their HIV, but they're managing co-occurring conditions and comorbidities in addition to their HIV. We saw that the Ryan White healthcare system as a provider was generally working when women were able to access services through the Ryan White program, but the major barriers that were reported were transportation, the cost of copays, and child care. We also saw disparities and barriers in mental health services where support groups there was high interest in support groups in seeking therapy and counseling, and also overall we saw still a very stigmatized level of sexual and reproductive health care that was inconsistent, and still a lot of stigma and sex negativity in provider communication with women living with HIV. Okay. So I'll hand it back over to Nana to discuss some of the primary recommendations that we have from the data so far and from the overall report.
Great. Thanks so much, Arnita, for that excellent presentation. So I'm just going to quickly overview our recommendations. And again, I encourage you to click on that link that I just put in the chat box, which has these recommendations in kind of a two-page format, as well as the findings that Arnita just presented. And all of this stuff is going to be presented in a lot more detail on our March 10th webinar, which we hope you all can join. And that'll be accompanied by the full report release. That'll be about a 12 to 14 page document. So number one, we think it's important, of course, and I think Barb put in the chat box earlier, MIPA. Yes, MIPA all the way. We want to make sure that women living with HIV and communities disproportionately impacted by the epidemic continue to be involved in all planning processes around the future of the Ryan White program and what it looks like on the ground. And with the integrated prevention and care planning that's happening now, joint planning from CDC and HRSA, that's even more important. So we want to make sure that continues to be written into the policy and the programmatic processes. There's a question about MIPA in the chat box. If maybe somebody can respond in the chat box. But I'll also say MIPA stands for Meaningful Involvement of People Living with HIV. That's a great question, Lori. Thank you. Secondly, it's critical, given the high rates of poverty and the way that HIV is really tracking with poverty, and that HIV actually creates more poverty for a lot of folks living with HIV post-diagnosis. One of our primary recommendations is the implementation of interventions that improve the fundamental economic conditions of women's lives. So for women living with HIV, really looking at microenterprise and other kinds of economic interventions, back to work programs, programs that support women getting job training that are linked with care and supportive services to really transform the fundamental economic conditions of women's lives. Thirdly, we think it's critical that the quality of care be improved. And so Arnita highlighted really well, sort of the subpar sexual and reproductive health services that are being received, and the need for a lot of attention to mental health, increased attention to mental health services. So those are two of the, primary things we think need to be fleshed out more in the future of Ryan White and in other forms and systems of care as we, over the next few years. And then also, in terms of improving the quality of care, we saw that, there are really high rates of co-diagnoses. 22% almost of our respondents were co-diagnosed with Hep C. And so the president's budget did allocate $9 million to providing, scaling up Hep C treatment, within HIV care settings, and we really want to make sure that kind of stuff is increased. There's an increased focus on it. Hep C, then looking at other types of comorbidities. Hep C is totally curable now, but it's a matter of making sure that folks have access to the treatments. And then we need to see continued investment and expanded investment in the types of services that reduce these structural barriers to care. So really looking at childcare, transportation access, co-payments, how, co-pays for prescriptions and for medical visits can be a barrier, how we make sure that those get institutionalized in the changing context of Affordable Care Act implementation, and like formularies, how formularies are working today, how the Ryan White program in the future can help to pay for some of the medications that might be tiered in formularies in a way that makes them less accessible. And then we also saw that child care is not only important for women of reproductive age. Women have lots of family responsibilities, and I know that this is not a surprise to any of you, but traditionally, child care has been mostly available only through the Part D program. And so for women with HIV who are, grandparents taking care of kids, have other types of family responsibilities, we really need to make sure that child care is available both in clinical and non-clinical settings to support access to services. Strengthening navigation between HIV and other types of systems is really important, and that can include things like vocational rehabilitation, which is, there are other federal funding streams that come into communities that we could be linking with better to, for example, increase access to employment opportunities, substance use, mental health services, and other types of things. We really want to focus on strengthening that in the future of the Ryan White program. And then finally, stigma in all forms continues to be a major barrier, and we have to find better ways to support folks in this diminishing infrastructure of support groups and peer support, where those things are kind of going away on the ground. We need to actually scale them up and expand them. We also need to focus on institutionalized forms of stigma and discrimination, including HIV criminalization laws, which have to be repealed. And then there are a range of stigma reduction interventions that have been shown to work that we really need to make sure are also prioritized for folks engaging in the care system. And so that's a really quick summary. We can definitely send these slides out as a PDF to you all who registered for this webinar afterwards. I see your question, Eva. We can do that for you. And I'm going to go ahead and just open it up for any clarifying questions. We probably only have a few minutes to take clarifying questions. It's *6 to unmute your line, and you can also ask in the chat box. So Lori, I see your question. No, we did not have, so the instrument was only available in English, and we had just a couple of women who were Spanish speaking who I think were helping to gather data. So that's one of the reasons that, as you'll see in the full report, when we explain why we think Latino participation was lower than, kind of the demographics of the epidemic, that's the primary reason. That's definitely something we'd like to work on further. We also didn't have a high number of transgender women participate, and our research team didn't include any women of trans experience. So that's something that we definitely want to, do some further work on in the future as well. Any other questions? Okay, well, I did paste the link for the Thursday webinar in here in the chat box. I hope that folks will register for that webinar. We'll be going over everything in a lot more detail. You'll really get to hear a lot from the researchers who were involved on the team, talking about their experiences and really sort of sharing their insights, because they actually, I'm sure it's no surprise to many of you, a computer administered survey only went sort of so far, right? So some folks were like sitting there and kind of going through the questions with people. So they got a lot of information in that process too. And so it'll be, I think it'll really add to the discussion to hear their reflections on the process and what they heard. And we definitely couldn't have done it without this full team of folks from all around the country who are just really fantastic. And that full report, again, will be available for you all Thursday, March 10th, National Women and Girls HIV/AIDS Awareness Day. And I'm going to turn it back over to Arnita to see if there are any other closing comments or questions.
No, I think that pretty much covers it. But thank you guys for joining. Like Nana said, we'll be having more full discussion of the entire findings from the report next week, but also the teaser report. There's a link to it here in the presentation and also in the chat box. So if you want to use that and print that, I think that's a really great tool just to hand to folks if you guys have events for National Women and Girls Day coming up. So please feel free to use that as a resource.
Okay, cool. Great. Thanks, everybody, so much. Have a great time with all your Women and Girls Day activities. We look forward to hearing from all of you about how you might be using this report and any support we can provide to you. Feel free to get in touch with us about that. And we'll talk to you all next Thursday, hopefully. Have a great weekend.
Thank you, guys.
Bye.